We're here at the University of Florida College of Medicine with Dr. Kelly Foote, who's going to tell us about a new treatment for Parkinson's disease called deep brain stimulation. Thanks for having us, Dr. Foote.
My pleasure.
How would somebody understand that they have Parkinson's? Because, are all tremors indicative of Parkinson's disease?
No. And in fact, all people with Parkinson's disease don't have tremor.
Okay.
People commonly associate tremor with Parkinson's disease, and that's a reasonable association.
More than half of those with Parkinson's have tremors, which affect people mostly when they are at rest.
There are other types of tremor, the most common one, essential tremor, which runs in families, that affect people when they're trying to use their hands, which, as you might imagine, is debilitating.
Sure. Yes.
Parkinson's disease is caused by a lack of dopamine, which is normally supplied to the network in our brain, which controls our ability to move.
When the dopamine supply is too low, we lose the ability to control our movements the way we want to, and we get stiff and slow, and we shake, etc.
Deep brain stimulation, or DBS, is a type of advanced therapy for treating Parkinson's disease that takes advantage of the circuits of the brain.
We've learned that the circuitry in the brain that controls our movement malfunction in a specific way in Parkinson's disease, and we've identified a couple of targets in the brain that we can stimulate, and if we deliver stimulation to exactly the right spot in the brain, we can sort of cover up this bad signal that's coming from those two spots and allow the rest of the motor network in the brain to function better. And what that translates to for the patient is their tremor gets better, their stiffness gets better. Deep brain stimulation, you might think of it as similar to a cardiac pacemaker,
where the device is surgically implanted in the chest, which then modulates the current in the brain in order to address malfunctioning circuits.
The FDA-approved indications for deep brain stimulation are tremor, Parkinson's disease, obsessive-compulsive disorder, and dystonia. Dystonia is another movement disorder. It's a dysfunction of the motor circuitry in the brain that results in the muscles working against one another.
You're not necessarily correcting the malfunctioning part, you're just sort of turning it off or bypassing it?
I wish we were that sophisticated. Yeah. No, actually we identify, this is a big circuit and a network. We identify a malfunction here, so a bad signal, and it's messing up the way the whole network's functioning, and we just sort of cover up that bad signal, if you will, to allow the rest of the network to do its job better.
Dr. Michael Oken, chairman of the Department of Neurology at the University of Florida.
Now, how does brain mapping come into play?
So what we like to do in order to accomplish deep brain stimulation is we need to understand what's going on inside. And so what we do is we push a little thing called a microelectrode, and the tip of the electrode is about the size of a hair. We push this tiny little hair right up next to the different cells in the brain, and we eavesdrop on them. We listen to them, and they're having conversations, and in many times these conversations are abnormal.
Doctors then monitor the nerve cells' electrical functions and build a three-dimensional map of the brain.
Who would be the ideal candidate for this type of deep brain stimulation?
So what we like to do in choosing patients is we put them through what's called an interdisciplinary evaluation. So that means they'll see a neurologist, a neurosurgeon, a couple of rehabilitation specialists, maybe a psychiatrist and a psychologist.
If it is determined that there is a target area where the device can be placed, the information is presented to the patient and family, and the decision to continue with the procedure is ultimately left up to them.
It's really critically important that we connect patients to information. There are, lots of resources out there, like the Parkinson's Foundation has a 1-800 number, 1-800-4PD-INFO. And on that helpline, there are Parkinson-trained nurses who are unbiased, who will help connect people to various teams, help them with experience. They have all the information about the devices. They have the latest information, free books and free booklets to help people to connect, because it can be a complex process.
John Alexander is a prime example of a patient with Parkinson's disease. He suffers from a significant tremor as well as stiffness and slowness.
Fall of 2009, I had a standard doctor visit. That doctor just gave me a routine examination, and he said, "What's up with the tremor in my left hand?" And I had never noticed it before. He brought attention to it, and he clearly said he felt it was a Parkinson tremor. So that led me to visiting my regular general practitioner. She ordered a brain scan and a trip to a neurologist who, after some observational assessment, declared that I did have, in fact, have Parkinson's.
The University of Florida was the closest for him and one of the top centers of excellence in the country.
One of the things that's fantastic about the University of Florida is they've got very much a patient-centric and team type of an approach. So even the way that they review and determine if a patient is a good candidate for DBS, they start with what's called a fast-track pre-assessment.
John underwent a number of neurophysiological tests to determine that he was in fact a candidate for the newest DBS.
From my fast-track pre-assessment at the University of Florida, one of the questions they asked me were, what were the symptoms that I would like to control? And I said that they were tremor, which is in my left hand, arm, and leg, but also some rigidity.
He wanted to improve his fine motor skills to help in simple tasks like retrieving his keys from his pocket and putting them in the door.
The third was a condition called dystonia, which for me exhibited itself in a curling in my toes that at times could be painful.
Lucky for him, these were the symptoms that DBS could help.
So the surgery itself, I was awake the entire time for this 4.5-hour procedure. And it began with having what's called a halo applied, which is a ring that goes around your head.
Doctors then opened a scalp with a small incision and drilled through the skull.
Now the brain and the skull do not have nerve endings as you would have throughout your body, particularly like your fingertips. So I did not have any sensation or feeling when he was touching those areas.
A path is then drilled to where the leads are placed and a plastic cap is installed. A month later, John returned for the neurostimulation generator implantation in the chest.
They're mapping out these sounds in the brain to make sure that the wire's in exactly the right place so it would deliver the proper power and benefit. When they applied the power and got it to just where they needed to, then those tremors went away. And that was amazing because that's the first time I had not had any feeling of that in like 6 years.
Since his procedure, John continues to return monthly for additional programming, and he is supplied with a controller that he can use to fine-tune the device to better control his symptoms.
A device that I have to control the symptoms is called a patient controller. This device can accommodate up to 16 different settings, but it does contain the app for the generator. I've had a variety of different settings that have been prepared for me, and then I also have the ability to make some mild adjustments within that. It changed what's called the amplitude, kind of ramp up the power or cut it back a little bit.
Since starting deep brain stimulation, John has been able to cut his medication in half. He says his quality of life is much improved, and he has gotten back to playing with his grandkids, working, and even competing with his daughter in 2 super sprint triathlons.
Deep brain stimulation surgery has been great, but it's not a cure.
John shows us how his symptoms immediately return when the DBS is turned off.
Simply tapping the device, that goes to red.
The majority of the programming is done by the clinicians. For most patients with Parkinson's disease, they never turn it off because when it's off, they are more debilitated.
Now, what's the battery life of something like that?
It depends on how much energy you use, right? Like any battery. So if I have to turn it way up, then the battery is going to last less time. In a really nicely placed DBS lead, where the current's going right where we want it to go, we might not have to turn it up very high to get the beneficial effect. Typical battery life might be 5 years. If we have to turn it up a little higher, then it might be 3 years.
Over the years, with technology improving, risk has decreased and benefits have increased.
How has what started as deep brain stimulation, how has it changed, say, to what John Alexander has implanted in him?
So it's been around for 30 years.
Sure.
Over the last 5 years, there has been a lot of innovation. And the driving force for that is there are now multiple companies that produce the deep brain stimulation hardware.
Each company wants to have the best device that helps patients the most.
The target that we're trying to stimulate to have beneficial effects for the patient is about the size of a pea. Well, as you might imagine, there are a whole bunch of other circuits around that target that we would rather not stimulate.
Stimulating the wrong area would have adverse effects, such as negatively affecting speech, walking, and facial expression.
So this new device, instead of having 4 cylindrical contacts that spread current evenly out from them into the brain, has 8 contacts, 2 normal ones on each side, but the two middle ones are separated into 3 segments that point in different directions.
Delivering current throughout the brain yields benefits in terms of tremor suppression, relieving stiffness and slowness, and improving speech.
The future of DBS is focused on self-programming devices rather than relying on a human operator.
We will eventually have deep brain stimulator devices that continuously record signals from the brain and identify malfunction in those circuits. And when they see certain malfunctions, they respond to them by delivering therapeutic stimulation to help. And so it's an adaptive type of deep brain stimulation that will do a better job. Yeah.
While not for everyone, deep brain stimulation remains the standard of treatment for several neurological diseases, including Parkinson's, and has given hope to many people like John Alexander.
To find out if DBS is right for you, talk with your physician or visit pdf.org for more information.
Well, thank you very much for telling us about these new strides in medical innovation.
Yeah.
My pleasure.
Thank you, Dr.
My
Foote.
pleasure.
Appreciate
Thanks
it.
a lot.